Some restriction on up-gaze. Case 1. Ocular motility examination. The patient had obvious bilateral thyroid eye diseases. There were some restriction on up-gaze, otherwise the movement was full. I was then asked if I noticed any other physical signs. I mentioned arachnodactyly and proceeded to demonstrate that the patient had coexistent Marfan syndrome. I was asked to list the possible ocular complications of Marfan syndrome. Differential. Case 2. Direct ophthalmoscopy of the fundus. The patient had a right optic atrophy. I was asked to give a differential diagnosis and the type of investigations that I would perform. The patient turned out to have a right optic glioma, but there was no evidence of proptosis. Case 4. Slit lamp examination of the anterior segment. The patient had a right corneal graft and abnormal iris stroma showing iridocorneal fibrous attachment. I made a diagnosis of Riger's anomaly. The examiner wanted to know the management of congenital glaucoma and the causes of childhood glaucoma. Conditions associated with us include dental anomalies, hypodontia, oligodontia, mycodontia, taurodontism, enamel hypoplasia, short roots, paraplasia, and delayed eruption. Facial features. Facial features. Mild craniofacial dysmorphism, telecanthus, hypertelorism, maxillary hypoplasia, and broad flat nasal bridge. Hearing loss. Sensorineural hearing loss disorder, which is a type of hearing impairment in one or both ears. Congenital glaucoma is treated with a combination of medical and surgical therapies. Surgery. The main treatment for congenital glaucoma is surgery, which can include goniotomy or trabeculotomy. The type of surgery depends on the severity of the disease, the clarity of the cornea, and the surgeon's experience. Medical therapy. Medical therapy can be used before surgery to decrease corneal clouding and to help control EOP after surgery. Medications include beta blockers, pilocarpine, and carbonic anhydrase inhibitors. Cycloablation. Cycloablation can be used if surgery fails, or if there is a poor visual prognosis. This procedure uses a laser or therapy to treat glaucoma. Lifelong monitoring. Patients with congenital glaucoma need to be monitored throughout their lives to ensure that EOP is controlled and to prevent further vision loss. Papillary examination on a middle-aged woman. She had anisocoria but without ptosis. Neither eye responded to light, but on accommodation, the larger eye constricted. The response of the small pupil is difficult to see. I mentioned that she may have bilateral Addis pupil, with the smaller pupil being the long-standing one. I asked to see the iris on the slit lamp. There were vermiform movements in both eyes. I asked to examine the knee reflexes, but the examiners appear satisfied with the diagnosis and did not want me to proceed. There was no Case 4. I was asked to observe the patient's eye and perform any examination as appropriate. I noted the presence of a downbeat nystagmus and went on to examine the nape of the patient. There was no surgical scar there. I mentioned the possibility of Arnold-Chiari's syndrome as a cause, and that I liked to examine the upper limbs for any evidence of syringomyelia. The examiners appeared happy with the response, but did not want me to perform neurological examination of the upper limb. The Parks-Bielski three-step test can help diagnose a left fourth nerve palsy. 1. Identify the hypertropic eye. In the primary position, determine which eye is higher. In a left fourth nerve palsy, the left eye will be hypertropic. 2. Determine gaze. Compare the hypertropia in the right and left gaze. In a left fourth nerve palsy, the hypertropia will be worse in the right gaze. 3. Determine head tilt. Compare the hypertropia in the right and left head tilt. In a left fourth nerve palsy, the hypertropia will be worse in the left head tilt. Case 3. Ocular motility examination. I began with cover-uncover test and noticed right hypertropia. I commented on this and proceeded to perform the three-step tests. The patient had a left fourth nerve palsy. I was asked about the muscle sequelae of fourth nerve palsy based on the Herring's and Sherrington's law. The other examiner wanted to know how I would test for cyclotorsion, that is the use of Maddox rods. Slit lamp examination of the anterior segment. The patient had heterochromia and slit lamp. Examination revealed left heterochromic cyclitis. Questions on the management of this condition and the complications which may occur during cataract operation. The patient had a mild right ptosis and small pupil. There was no heterochromia. I diagnosed right Horner's syndrome and proceeded to examine the neck, right hand muscles and the pulmonary apex, but there were no signs to indicate the cause of the Horner's syndrome. The examiner asked me the pharmacological testing for pre- and post-ganglionic Horner's syndrome. Case 1. Indirect ophthalmoscopy with a 20D. The patient had a right macular hole. Questions on causes of macular hole, its staging and management. Case 2. Slit lamp examination of a middle-aged man with bilateral corneal graft. There were opacities on the recipient cornea which may be granular dystrophy. Questions on different types of stromal dystrophy and inheritance. Case 3. Slit lamp examination of an Afro-Caribbean middle-aged female. She had a right thumbsical eye. The left eye had trabeculectomy. Fundal examination shows extensive peripheral chorioretinal scar. The scar looked like heavy pan photocoagulation, possibly with the old-type laser like xenon laser. Questions on antimetabolites and their indication during trabeculectomy. Ectropion. Indirect ophthalmoscopy with a 78D. The patient was a woman in her 20s. She had bilateral ectropion uvo and fundal examination revealed a right exudative retinal detachment with extensive exudates. I looked for peripheral telangiectasia and angioma, but there were none. Questions on the possible diagnosis. I was also asked to perform confrontational visual field test on the left eye, which was normal.